This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Good morning. Dr. Halfon has a full presentation today, so we're going to try and get started on time, which is unusual for these grand rounds. But the title of his lecture today is Leveraging the Science Health Development to Transform the Health System from 2.0 to 3.0, which makes me wonder what 1.0 was. Dr. Halfon is a professor at the David Geffen School of Medicine, the Department of Pediatrics. He's a professor at the Fielding School of Public Health, the Department of Health Services, and a professor at the UCLA Luskin School of Public Affairs, Department of Public Policy. In looking at his CV and speaking with him today, he's done work either through undergraduate, medical school, graduate school, at nearly all of the UCs, so has a breadth of experience within California. For more than a decade, he's worked with national, state, and local initiatives aimed at really improving early childhood systems. He's developed new conceptual frameworks for the study of health and health care. He directs the Transforming Early Childhood Community Systems initiative, which is a collaborative venture with United Way Worldwide. He's associate director of the UCLA CTSI, and he served as a member of the board on children, youth, and families at the Institute of Medicine and the National Research Council. In 2006, he was awarded the Annual Research Award from the Academic Pediatric Association for his contribution to the field of child health research, and I think we're going to be seeing a lot in the future of changes within the healthcare system, and perhaps he'll give us a little sneak preview of what may be ahead. Dr. Halfon.
Good morning, everyone, and it's great to be here. I have nothing to disclose, and I won't be discussing any off-label prescribing of pharmaceuticals or other treatments, in case you were wondering, with the title of the talk. I also want to acknowledge several folks. This talk has evolved over a couple of years. First, the LCHD Life Course Research Network and the funding that we've had from them to establish that. Also, the NICHD Life Course Health Sciences Working Group, and particularly Chris Forrest and the measurement team is working on the National Children's Study. Also, the Child Health System Transformation Initiative. So you see I'm involved in several networks. And then lastly, Clyde Hertzman, who's a colleague of mine that passed away last year unexpectedly, who did a lot of the work in this area, and you'll see some slides from him. And then also, I've had an opportunity as a visiting professor to give this talk at several universities over the last year and had gotten great feedback, so that's all been woven into this. The learning objectives basically is to understand the pressing need to transform our health system in the United States, to appreciate the revolution that's taking place in the life course health sciences, and specifically the life course health development, and to consider how life course health development informed 3.0 system transformation framework can be used to provide strategies for how we change the health system moving forward. So what I'm going to do is talk about this pressing need for change. I'm going to talk about this new science and paradigms, both using complex systems analysis and life course health science, talk about a transformation, and then I'm going to show some prototypes of what the health system might start looking like and how we sort of move there. just to start off, we have the most inefficient, low-value, low ROI health system in the world. So that should give us all sort of make us feel good, I guess. We have this current triple aim of improving the population health, improving quality at lower cost, and that's actually what all the health systems are aiming at right now. But we have all these challenges: enormous disparities, rapid rising rates of chronic disease, unavoidable demographic shifts that are happening, and relentless cost increases. And we have a really tired health policy that does not reflect what we know about producing health. And we have an operating system that's driving the entire health system that that's old, outdated, and isn't working. I'm going to show just a series of slides very briefly, just to make the point that our health system isn't functioning very well. This is something that I'm sure all of you have seen, and shows that how healthcare costs in most countries are going up, but that we spend much more than most other countries, but we have actually worse health outcome than all other countries. So that whether it's healthy life expectancy, whether it's looking at access to care, or use of electronic health records and the like, we're sort of at the bottom end of the spectrum. What we also know is that the cost drivers in our health system are really being driven by chronic disease, and it's the increase in chronic disease over the last several years that has really been one of the major chronic cost drivers. And currently about 83% of all Medicaid dollars goes to chronic disease care, 75% of all dollars overall. And what we know is that these chronic diseases are increasing, and this is just one study that was measured that Ken Thorpe did from Emory, showing that these disorders are going up. And what you see here is, mental health, and I'm going to talk about that because I think the mental health disorders are the new obesity. We're seeing an epidemic of mental health problems that are going up. Hyperlipidemia is probably a Lipitor effect, but you see these other kinds of changes that are going on. And in the IOM report that came out about a year ago on why the United States is the sickest of rich nations, showing that we have shorter lives and poorer health than almost all other OECD countries, part of what it pointed out, and this is a little bit of a difficult slide, but it's showing here average health service expenditures per GDP, as well as average social expenditures. And the point here is that all other countries like ourselves spend almost exactly the same amount of money on health, education, and social services. The thing is that what we do is we spend it all on health care at the end of life for treatment once people are sick, and the other countries are investing in social and education services early on in life so that their populations are much healthier. And we see this in the OECD report on the nations, comparing the 28 nations across the world, and you see where the United States ranks, and we have actually the worst health outcomes of the lot. And so the important issue here is that when we look at us in relationship to all these other countries, and we see that we're at the bottom of the barrel in adult health and life expectancy and other things, we start off at the bottom of the barrel in childhood. So the die is being cast early on in the lifespan, and we're not doing much to change this. So when we look at how children are in the United States and look at the epidemiology, we know that mortality rates continue to decrease, and that's really a good thing, right? And we know morbidity is decreasing for many medical conditions, but disparities in health outcomes are actually increasing as social inequality increases. There's the emergence of many new morbidities and concerns, including obesity, ADHD, mental health concerns. And the patterns of exposures are changing very rapidly as families are squeezed in terms of resources and time, that children are hurried in terms of their developmental path, and that the toxicity of the environments in which they live, we don't recognize in terms of the effects that it's having. And we're all really familiar with the obesity epidemic that snuck up on us, but is having profound effects, not just on children's health, but on lifespan at this point. But we know that we have this increase in chronic health problems, and it's not hemophilia, cancer, and congenital heart disease that is going up. And we have somewhere between 16 and 33% of kids that have chronic health problems. So the child health population ain't healthy. And that, when you factor in, obesity, it goes up to around 33%. Have a growing prevalence of mental health problems, and actually those numbers are wrong. We know now that 22.8% of kids, adolescents, have mental health problems with impairments, and over 35% of adolescents have mental health problems at this point. Have greater appreciation of the role of neurodevelopmental issues and a growing number of children with multiple chronic conditions. And I'm saying this, and I'll say this to our pediatric colleagues here, it's kind of interesting that we don't have a neurodevelopment program in the Department of Pediatrics at present, when the epidemiology is showing that this is where everything is headed. This is looking at disability rates in the United States for children from 1960 to 2008, and what you see is disability rates for children are going up and up and up. 1960, the poster child for disability would have been a little girl on crutches and braces because she had polio. In 2008, the poster child's a kid with autism. And we've seen a huge change that is going on. And I don't think this is something that we think about very much, that kids are becoming more disabled in the country. The trend is going in a direction that, I don't think many of us recognize. The other issue that I want to show here is that the mental health problems, that 70% of mental disorders have an onset prior to the age of 25, and recent estimates suggest that over 30% of adolescents have mental health. And most of the action in terms of the developmental mental health is during adolescence. And so that we're seeing this, massive increase in children with mental health problems. And the important issue is not only is adolescence a sensitive period of development in terms of mental health, but it's critical in terms of lifelong health issues. So when we look at the number of children at risk, what we see is we have 4 to 6% of kids with severe disabilities, about 12 to 15% of kids with special health care needs, but about 30 to 40% of children that have behavioral mental health or learning problems. And about 50 to 60% of kids are good enough, And I put good enough up there somewhat tongue-in-cheek because I think any of us that are parents, don't look at our children and say, okay, you're good enough. Well, unless you have an adolescent, and then you probably do. But what we're concerned with is what percentage of kids are thriving. And we don't know if it's 30%, 40%, or 50% because we don't measure that in this country. And that's actually one of the issues that we're wrestling with at a national level is how do we get better measurement systems in place, not only to measure disability, but to measure how children are thriving. So what we know is driving much of this is economic adversity. And we know that children that are born under conditions of economic adversity, and I don't mean just poverty, okay, not just below the federal poverty level, and I'm going to talk about that. They're born earlier, smaller, more fragile at risk. They have worse physical, cognitive, emotional health. They're hospitalized more. They're more obese, more asthma, and other chronic health problems. Lower lifelong health trajectory, huge brain drain that goes on in the first years of life. They carry this burden with them for the rest of their lives, and it's being programmed into their biology, into their immune, endocrine, neurologic systems, and as they develop and function. Much of this is invisible during childhood, during your well-child visits when you're seeing kids at Olive View or Harbor or here at UCLA, but this is brewing and moving forward, and oftentimes we're looking at the wrong things when we're actually examining these kids. We still have well-child visits that are organized around providing immunizations, whereas in fact those aren't the major issues, with all due respect to Dr. Cherry and the current measles epidemic that's going on and the fact that we do need to be immunizing for pertussis and various other things. But the big issues that are happening are others, and we need to be really thinking about how we organize our care. And we know that the differences in brain development start early in life. This is the Hart and Ridgely studies that were done 20 years ago, but we see by 16 months of age, you start to see vocabulary development changing, and by 36 months of age, you have twice the vocabulary. And this is the so-called 30 million word gap that the White House just had a conference on because they're concerned about brain development of children. And what you see is this differences start early and are compounded over time. And although we're talking about vocabulary, what we're looking at is how the brain is developing. And a recent study that was done across the US and Canada showed that as they started to scan kids' brains across social classes, you see the same thing in terms of the total gray matter development. And you see the same trajectories, so that if you could look inside the brain, this is what you would see, And basically now we've looked inside the brain and we know that what Hart originally showed in these kids and poor kids and vocabulary development is actually mirrored in terms of the physiology. An important issue to realize is that we have a chronic problem of poverty in our country. That what you're seeing here is the little dip that took place during the Great Recession, and we see that what happens here is we've gotten up a little bit in poverty, but before, when we were actually thriving, we have 22% of our kids poor, 44% of them near poor. And what the research clearly shows is that under 200% of the poverty, you don't have the resources that you need to raise a child in America today so that they're thriving and optimizing their development. It just doesn't happen. And we can't approach this by creating more safety nets and creating more kind of ladders to opportunity, which the Obama administration is talking about. We have to rebuild the bridges that exist, not throw out more nets to catch kids that are falling, because when you have 40% of the kids under 200% of the poverty level, they're just not going to make it in the ways that we want them to thrive. And what we see this in the same way when we're looking at entry into school, you see these huge social gradients in terms of math and reading scores when children start school. And our health system isn't doing much to deal with it. There's service delivery, is incredibly fragmented. We have continuing difficulty accessing services with huge inequities in terms of service delivery, low and uneven quality, models of care that are outmoded and don't match current needs, whether it's the structure of our well child care or the fact that we're still using Head Start, which was designed in the 1960s during a different era to be our main program for child development. And we have limited local responsibility and are operating under enormous economic constraints. And this is Rita Mangione-Smith's study that was published in the New England Journal, and I use this because what it shows is only 46% of children are getting the health care that they're supposed to get in terms of the ambulatory care that they need. And this is lower than what the adults were getting. The same study that they published for the adults was 53%, so the kids are doing worse than the adults are. So what we have is we have ideal trajectories that children could be developing into, and we have what's actually going on in the United States, our current practice. So we have this enormous missed opportunity, and we're not focusing on how to actually leverage this, not one child at a time, but as a society, how do we leverage the change that needs at a population level? Because this isn't a one child at a time screen and find the kid with the problem and change it. This is a bigger problem now. So when we think about these new challenges, we have to think about new paradigms and new strategies. And the new paradigms in systems biology and health development and actually how we organize our healthcare system. So I challenge you to think differently. And we have tools for thinking differently. One of the things that we've been concerned with for forever, whether it's in our literature or our science, is the arc of human development and connecting the dots between what happens early in life and what happens later. This is a Blue Shield ad that came out several years ago. But what we know is that over the last 100 years, what's happened is the life course trajectory, meaning the health of the population, has actually increased by about 30 to 40 years. When we went from lifespan of 47 years to almost 80 years, the health span has increased dramatically, and the performance span has increased. So that what we've seen over the last 100 years is we've seen the shift in the life course trajectory of individuals. What we know is that these trajectories are variable, and you can go into a high trajectory or low trajectory, and I'll show you that this is the same, whether you're looking at endocrine function or forced expiratory volume in the lungs or neurodevelopment, they all follow these same sort of trajectories. And what we know is that when you have lots of risk early in life, you go into a lower trajectory, and protective factors send you into a higher trajectory. And the important thing from a public policy standpoint is you become symptomatic earlier. When you have lots of risk early in your life, you become symptomatic with chronic disease when you're 50 or 60 rather than at 70 or 80. And what that means is that we pay for this. This is a huge amount of cost in our system, and this is what the other countries aren't paying for, because they're making sure that people are launched into a higher trajectory. Now, the National Academy of Science, the Institute of Medicine's Children's Health Nation's Wealth report that came out almost a decade ago tried to engage and involve this more life course oriented in the definition that it came up with, which was children's health is the extent to which individual children or groups of children develop and realize their potential, satisfy their needs, and develop their capacities. The reason why this definition is important is it's a developmental definition of health. It's not health as a state, health as a capacity. It's a developmental capacity. And what it is embodying is the understanding that kids can go into a delayed or disordered trajectory, that toxic stress, lack of health services push down. And if we want kids to go into a high trajectory, we have to make sure that they have the things that they need in terms of their parents, in terms of the activities and behaviors and the like. And from the standpoint of our society right now, we have about 40% of the kids in this area. And that's unacceptable. And it should be a national shame to us. And we in pediatrics aren't doing much to change this. Disability rates are going up. What we know is that the distribution of risk factors aren't the same, so that as you get early in life, family factors, school, daycare, community things are more important. As you get older, individual behaviors take over, and we see the sort of contours of risk during the lifespan. But what we know is when we start to look at it, whether it's at obesity or what we see is that the increased risk has to do with what happens during those different periods. So that we understand that the accumulation of risk, this cumulative process across the lifespan, is very important. But it ain't simple, right? Because when we think about obesity, it's not just the mother's behavior during pregnancy or toxic stress or the SES or what we know, and this is from a map that was done, and we look at obesity in the middle there. It's a very complex process, so that you have individual psychology, physical environment, you have all these feedback loops that are happening. And what complex system science is telling us is that we need to understand when we're dealing with a simple system, a complicated system, or a complex system, or chaotic systems. And I'm not going to deal with chaos, although much of what we see happening in our health system sometimes feels like chaos. So a simple system is a mechanical pump, or giving immunizations is a simple process. A complicated system is an airplane. And most of what we do in treating most medical conditions is complicated. Health development and child development are complex, okay? And what I mean by being complex is that they function in different ways. And so you can build a simple system, you can design and construct this grow and develop. And this is just a picture of what the characteristic of complex systems and complex biological systems. And what is important about a complex systems is the elements of the system themselves are constantly adapting. You have complex emergent behaviors so that you have simple systems in the cells that are actually complex, but let's say that they're simple, that aggregate and self-organize, and you see this emergent kind of behavior. An emergence of novelty and creativity is a natural state of complex systems, that order emerges without central control. There's nonlinearity and the like. So that we need to be thinking about and modeling not simple systems, and that's part of what we've been doing, is reducing to simple when in fact we're dealing with much more complex systems. And so when we think about this conceptually, we go back and look at how our evolving concepts of health and development. We started with Mendelian genetics, germ theory, and cutting people open and looking at the lesions that they had, and that led to the biomedical model. The biomedical model was simple, mechanistic, and linear, and that's what sort of built our modern medical institution. But what happened is, as we started to do more epidemiologic studies, and Framingham is the great example, we started to realize that heart disease wasn't bad luck genes and, junk in the arteries, but it had to do with what you ate and what you drank and how much exercise, and there was all these factors that contributed to it. And we realized that behaviors were important. So then we came up with this biopsychosocial model. So it was not just biology, but it was the interaction of biology, psychology, and the social environment. And that was a hierarchical model in using dynamic systems and talking about multiple determinants of health. Where we're headed, because of the lifespan development work and life course development work and the epigenetics and DOAD work, looking at how disease develops, is towards this life course health development model, which is about complex interactions and the relationships of these various systems in a dynamic and development context. And what's important is this relates to what's going on in systems biology or in biology, which we see the neo-Darwinist synthesis that I was taught in medical school, which was the one gene, one protein, one phenotype kind of notion, which has now been thrown out completely by systems biology. And we have this new post-genomic synthesis that's all about relational gene networks. And I won't go into this, but there's a whole issue about what this means. But what we're seeing are these worlds coming together. And we're seeing this new paradigm emerging about health development, about health emerges and what that's all about. And so some of the principles of life course health development is that health is actually an emergent property of living systems. It develops over the lifespan continuously, and it's continuously evolving and changing. That health development is a complex, nonlinear process that results from person-environmental interactions, and it's multidimensional, multidirectional, and multi-level, so that it's happening at all these points in time. And that it's highly sensitive to the timing and social structuring and environmental exposure. So that's what I'm showing you. When kids are talked to, more words, brain develops in different ways, and it happens during certain time periods. That evolution has played a huge role, and we don't think about the evolutionary forces that are going on, but right now we have an enormous amount of evolutionary pressure on our brains. That's what's going on as we move into an IT world where we're putting lots of pressure on our brains to perform more, and that's part of why we're seeing the differences in our mental health. Just like we had a mismatch between our Paleolithic metabolisms and the environment that we live in terms of obesity, we're having a mismatch between what our brains are being asked to do and how they were originally designed and developed. And optimal development promotes survival, enhances thriving, and there's this whole set of timing issues that have to do with how the synchronization of what happens at a molecular level and what happens at a cultural level are actually related to each other. And we now know that every cell in the body has a clock in it, and that the mitochondria aren't constantly just churning out, but they're actually working in timed ways. And so that this timing is very, very important in all ways. Again, this is could go on and just do a lecture on that one topic, but I want to give you a sense that there's this new paradigm emerging that's about how health develops in a developmental way as a complex system. And we see this in these trajectories that, whether we're looking at brain development, we see the trajectory in brain growth, or we look at brain function, and this is looking at glucose metabolism, and what you're seeing here is by about 15, 16 years of age, you sort of see the changes. This is looking at synaptic density and the changes that are going on. And what we know increasingly, that exposures like toxic stress that affect the epigenome are affecting different parts of the endophenotype, so that toxic stress during early childhood affects the midbrain development in terms of affiliation and attachment. It affects the prefrontal cortex in terms of executive function, impulsivity, and ability of executive function. And we know it affects the HPA axis in terms of stress response, in terms of the allostatic load. And what we know also happens is that it affects phenotype in various different ways in terms of chronic disease. One of the best examples of this comes from Moffitt and the Dunedin study that's been looking at childhood risk factors, adolescent issues, and adult health. And this is from a PNAS presentation that Terry Moffitt did a couple of years ago. And this is, to me, is very profound. When you look at self-control in early childhood, and you look here, and you start to look at issues that have to do with functioning over time, and I know this is hard to read, and even for me to read, but this is looking at physical health. And the kids that have poor self-control have worse physical health, and you're looking at here whether or not the percentage of them are in single-parent homes. Or if you're looking at here is criminality. What you're looking here is their socioeconomic status. So if you had low self-control in prefrontal cortex development as a child, your social status as an adult is dependent on this. So these are, I think, are really profound revelations in our understanding of sort of what happens early on in life. Understanding that adverse childhood events, the number of adverse childhood events, is highly linked to whether people develop depression, whether they develop heart disease. And so what we're seeing when things don't go right in the first decade of life, we see by the second decade of life, all these things start to happen. By the third decade of life, you have higher rates of obesity, elevated blood pressure, depression, coronary artery disease, diabetes, renal disease, arthritis, and old age, premature aging, and memory loss. One could argue that Alzheimer's disease is actually a disease of early childhood. And that what we're seeing in terms of the neurological reserves that people actually have to do what was happening early in their life in terms of what was going on in those lower trajectories that we're seeing. What's important about this is that we can use this in various ways. So for example, with a CTSI, we can start thinking about how do we think about T1, T3, T4 kinds of research and start linking across these different ways. But importantly, it makes us think differently about health and health development. So most health disparities start early in life and are the result of small differences compounding over time. Most chronic diseases start early in life and have to do with adversity behavior and these early pathways. And if we're going to shift the cost curves and we're going to make the healthcare system work better, we have to be thinking about what the drivers are and what are these sort of more system effects, and how do we shift things. And we need to approach it in a different way. And one point I just want to make very clear is this should be raising the stock of pediatrics and child health, because all the action in terms of lifelong health and costs is actually happening early in the lifespan where we're doing things. Yet we're the least paid and least valued and least everything in the healthcare system, fewest resources going to it. Yet we have more probably influence, than any other part in terms of the overall cost of what's happening. So to shift gears now into another thing, well, how is this informing how we think about policy and how do we think about how our health system functions? The story here is that we've had 3 eras of healthcare, 3 major transitions. The first era was focused on saving lives through acute care, emergency and rescue care, and public health safety. And that goes back from the 1800s to about 1950. And life expectancy was about 45 years and starts to increase to about 65 years in 1950. And then we go into a second era, which was focused on prolonging life, decreasing levels of disability through chronic disease management and secondary prevention. And we're on the cusp of a third era, which is about optimizing the health and development through primary prevention, health promotion, and community integrated systems. And the way this looks is the first era focused on acute care and infectious disease. It was driven by the biomedical model. It was about short time frames. People got coughed on and got sick immediately, or something fell on their head and they got, brain injury. But it was all short time intervals that people were managing towards, were thinking about long term. And this is where we developed our medical care model. We created insurance-based financing. It was really built on an industrial model of actual production. The focus was on reducing deaths. As people lived into their 60s, and 70s, we focus more on chronic disease, and we move towards this biopsychosocial model. The important issue is the chip in the first era is the biomedical model. We start moving towards this biopsychosocial model, and we're managing health over much longer time horizons. So we're thinking not days and weeks, but we're thinking weeks, months, years, and decades if we're thinking about chronic diseases and chronic disease management. We completely changed the financing system, right? And we go from indemnity insurance to prepaid health benefits over a longer time intervals. And we're moving towards a corporate model of healthcare. The ACOs of the Affordable Care Act are basically the Kaiserification of the entire health system. It's basically how do we form corporate entities to deliver healthcare? And that's what the health system's been trying to do. And the focus is on prolonging disability life. And where we're headed is increasing focus on achieving optimal health, because we now know what it takes to be 80, 85 and be healthy. And the focus is going to be on these life course health development issues, which are both lifespan and cross-generational in their focus, because we know maternal health affects children's health, but we also know that the eggs in the child during the grandmother's time is actually having an influence on the 2 generations forward. And these are going to be requiring different kinds of ways of providing health care. So we've gone from this 1.0 model to the 2.0 model, and we're headed towards a 3.0 model. So that's Rick, what you were asking, what was 1.0? Well, there's 1.0. The United States health system is about 1.5 to 1.8. Much of our inner cities is about 1.0 in many cases, where we're still just providing basically rescue care. Most of Europe is at about 2.2 and moving in that direction. So we have a lot of work to do, right? And most of the folks in Washington and CMS are sort of saying, well, we just need to get to 2.0 now. But what's happening also, which we should recognize, is that CMS in the country now is in the lifelong health business. We used to have Medicaid and Medicare, and Medicaid was for the young, and then we had Medicaid and Medicare for the old. Because we have no social mobility in our country right now, 44% of people born in the lowest quintile, born into poverty, will remain in poverty for the rest of their lives. And because of the ACA, they'll be on Medicaid for the rest of their lives. So CMS is going, gosh, we're going to have to take care of these people forever. So maybe we should be thinking differently about what we're doing. And so they're trying to change what they're thinking. And so this, just going back to this model I showed you, the 1.0 model, 2.0 model, 3.0 model. So you sort of see there's 2.0, that's the biopsychosocial model, but where we're headed is this model. So if we want to be out ahead of the curve from our science and from our research and pull things forward, we need to be thinking about how do we move towards these health development models, and that's where our research should be focusing. Importance of this is, again, back to these trajectories. So you can go a high or low trajectory. Most of the actions early in life, you get symptomatic, but this is what the cost curve looks like. Okay, when you start getting sick, the costs go up. And you become symptomatic in that way. If we were to invest more early on and people became symptomatic much later, we'd have a different cost curve. And this is important because the whole rallying cry of health policy right now is around bending the cost curve. You can talk to anybody in the health policy environments about bend the cost curve. Well, I would argue that that's a fool's errand, that we're not going to bend the cost curve by just squeezing more money out of emergency rooms and out of sick care. That what we really need to be thinking about is how we move from 1.0 rescue care or 2.0 care to actually what 3.0 care, which is about moving upstream, not just socially, but it's also about moving upstream in the developmental ways. And start to think about not just how we bend the cost curve, but how do we shift the health curve to a higher trajectory so that we shift the cost curve. So we should be thinking about how are we curve shifters? How are we going to shift the curves? This is what CMS came up working with them about the 3.0 system. So they started to model what this would look like. So we talked about what 1.0, sick care focus. This is about, moving towards patient-centered care, accountable health systems, shared financial risks, integrated HIT, what healthy population-centered care would look like. And so they're starting to think about what 3.0 systems are like. And in fact, the state innovation models that were just put out by CMS were, about $500 million was put on the street for states to start innovating, was really for them to start moving towards 3.0 and to start putting things in place that allow this to happen. So when we think about transforming the health system, we need to think about what are we trying to do? Well, we're trying to transform the logic of what we're doing. So we're trying to go from the old logic of the absence of disease, focus on individual, the biomedical model around diagnosis and treatment, to a new operating logic that really thinks about how do we use that IOM definition of what children's health is. How do we optimize health potential of population? How do we use this life course science to move forward? So we're thinking about health from a lifelong and continuous process. So it's a shift in the operating system. If we stay with the old operating system, we'll continue to do what we're doing. How do we organize our healthcare differently? Well, currently what we have is we have different funding streams, funding health plan A, like it could be Kaiser or UCLA Health System. But all of the prevention services are all funded differently. So you have mental health and school health and early intervention, Head Start. The reason why it's so hard for us in the primary care pediatric world to get the services we want, because they're in a completely different system with a different operating system and different funding. They're not connected in any way. But, people are thinking about what integrated health systems look like. This is from Nemours in Delaware. And they're interested in the productive, interactive relationships, not just between doctors and patients, between communities and the entire health system. So how do they create interactions between the community level and the health system? What needs to be in place to do that? How do we redesign the system and think about it differently? So this is a model that we came up with. If you want to have an integrated health system, you need to have integrated finance mechanisms. And you need to be thinking about how you bring your money together differently. The California State Innovation Model Grant in the governor's office is starting to think about what would a health trust look like for a community, where you took all the money and brought it together and created kind of a global budget for healthcare for both individual and population health, so that you could fund things differently in a more integrated way, so you didn't have 80 different funding streams trying to pay for things. And then how do you start to integrate care? So you have primary care centers and community health teams, I'm showing here, and primary care resource centers, like family resource centers, like the Hope Street Family Center or the Magnolia Community Health Center. We're starting to see this stuff emerge right now. And where the family resource centers and early intervention school health is all integrated in, where we have measurement and IT systems that allow these systems to work just the way that our financial institutions and others use these systems to connect things up. And then we create a different kind of value portfolio. So this is redesign, re-engineering to create different value. And the value is not just reducing morbidity and mortality, but it's about producing healthcare of higher quality at less cost, but most importantly, it's about investing in the long-term health capital of the population. And we could think about what the organization of pediatric care, I'm not going to flip through this, but it's an important point that if we want a higher trajectory, what you're seeing here down at the bottom is the nurse-family partnership, home visiting, early Head Start, Reach Out and Read, early Head Start, the Triple P parenting program, patient-centered medical home, school readiness. The point here is that you have a higher trajectory here, a lower trajectory. If you want a higher trajectory, you need to have programs that are linked together, horizontally linked. So it's not just having primary, secondary, and tertiary care, but we have to horizontally link so that healthcare is connected to social care, early intervention, early education, and it has to be longitudinally linked over time. What you're seeing here is that what I've done is built a scaffolding around that higher trajectory by using these integration strategies. Just the same way that this building has scaffolding in it, because we have building codes that we build with in order that earthquakes won't knock the building down. we need to be thinking about what are our building codes for our health system, because we have lots of children living in environments that earthquakes run through their lives on a daily basis. And we're not building the health system with the building codes that they need in order to take care of them. We have to be thinking about, the pediatric office, chronic and acute care. We've been doing acute care, connected us to the emergency room, chronic disease care, connected the pediatric office to all the specialists. But if we're going to do preventive and developmental care, we have to be connected to all these other things, which we're not. And in this era of massive connectivity, we're not doing this kind of stuff. I mean, there's projects like Help Me Grow that are happening in Connecticut and Orange County and the like that are doing it, but we're not doing it routinely. I'm just going to flip through. There are a bunch of other re-engineering things, but I want to get to the last thing. So part of what I'm arguing is that we have to have big, bold, transformative change. We need a child health community to start committing itself to what should child health in 2025 actually look like. What should our system look like? Are we going to keep our heads down and keep working on our individual projects in isolation by ourselves? Or we start to look at the horizon and say, where are we trying to get to, and what's the roadmap to the future? How do we start changing, re-engineering, and making our research align with where we want to go rather than where we've been? How do we stop looking in the rearview mirror and using past data from 3-4 years past, and how do we develop dashboards that tell us where we need to head? How do we adopt a 3.0 strategic framework for research and transformation, and how can children lead the way in transformation of the health system? We're only 6% of the dollar on any kind of healthcare contract. That's why we're not paid attention to very much, because we don't matter, we don't cost. We're like the rounding error of any contract with a health system. So we're acknowledged, but nothing more than that. But that's actually an advantage, because we're cheap in relationship to what everything else has happened. So kids can we can make more changes in the child health system for less cost. But we also have to make the unnecessary and catastrophic loss of health potential, this brain drain that's going on, this loss of health and health care that's happening, an unavoidable and inconvenient truth for our country. And we as pediatricians need to be doing this, because we understand this. We're seeing these kids, and we need to understand what's going on and make this clear. And we also have to be thinking about how are we going to transform the health system. How do we develop 3.0 research, delivery, organization, payment? All the stuff that we're doing, we should be thinking through a 3.0 lens. How are we getting to that? So just to finish, I want to talk briefly about the ACA and children's health system in California and elsewhere. Children's health services were not a major focus or concern in the ACA reforms, but will be affected in ways that could lead to real systems innovation. But there's early evidence and growing concern over the potential loss of several hard-fought improvements in the delivery of services for vulnerable children and children with special health care needs. So there's this opportunity with the ACA, but there's huge challenges with the ACA that are going on. So the ACA had many positives: expansion of health insurance for parents, no lifetime caps, no discriminations on pre-existing conditions, better access to preventive care. So those are all very good things that children benefit from. But there's starting to be a breakdown in regionalized care, perinatal care, and chronic disease care that's going on. Squeeze on children's health services in the community health centers, because community health centers are increasing the number of frail elderly and other newly insured people, and they're getting paid more for that, so they're squeezing down what's happening with children's health care across the country. You have challenges for children's hospitals. How many of you recognized when the ACA was passed that 10, 20, 30 children's hospitals in the United States would probably close? I know I didn't think about it. I was in the Senate Finance Committee hearings when they were talking about various kinds of things, and no one sort of said, gosh, because of the ACA, because we're going to turn the entire healthcare system over to the marketplace, and we're going to create these supermarkets called exchanges, we're going to turn everything over to this marketplace, that maybe the children would suffer from that because there's been nothing but market failure for 100 years in terms of children's health care. The reason why we have Title V and CCS is because of market failure. The reason why we have Head Start, we have all these government programs, is because of market failure. Yet we've turned the entire health system over to the marketplace in terms of moving forward. And what we're seeing across the country is the children's hospitals are scrambling to figure out how they're going to stay in business as other places gobble up all the primary care practices. And it's different in different states, but you go to the state of Ohio, and people like Kelly Kelleher at National Children's Hospital are talking about how pediatrics is basically roadkill in Ohio. And you're seeing them, you know, their ability to continue to function is really in question. And the child benefit packages aren't great, and there are all kinds of other things that are happening. So there are all kinds of negatives. And the problem is, for most of us who support the Affordable Care Act, you can't raise your hand and say, hey, but wait, there's all this bad stuff happening to kids, because where does that lead you? You end up on Fox News, and you're throwing meat to the angry birds that are, you know, hate the Affordable Care Act. I love the Affordable Care Act, but I think that there are things that it could be doing and doing better, but we don't have the opportunity to actually do that right now. Hopefully, you know, with Obama now saying that 8 million people, and he's saying, you know, time, this is over, we're not going to fight about this anymore, maybe we can start to fix the Affordable Care Act and make it better for kids. But we need to be thinking about the fact that, you know, there's a lot of disincentives. Children are just viewed as a special population. You know, at our exchange here in California, they just think about children and AIDS patients and everybody else. We're just a special group. We account for a small percentage of overall expenditures. The investments only show potential benefits over a very long time horizon. So we're dealing with this, we're always going to be this, and this is the reason why we have market failure. Because the market works on short time frames, and we're working on a long time frame. So care integration raises difficult questions about how we cross-sector finance. How do we connect with schools and various other things? Because a lot of where health is happening for kids ain't in the doctor's office. And we've never fared well in competitive markets. So what we need to be doing is minimizing harm during this period of enormous disruptions that's going to go on in the healthcare system over the next 10 years. And we need to maximize gains for children. We need to catalyze transformation and leverage all the tools that are in the ACA and related efforts to kind of synergize them so we're actually moving the child health system forward. What if, you know, Long Beach or San Diego, I'm not going to say LA, committed that over the next 10 years they're going to transform their children's health system so that it's going to be a 3.0 system, and they're going to bring all their resources together to do that. So part of what we need to be doing is forward-looking monitoring and analysis. We need to have real-time learning and innovation and rapid prototyping of things that allow us to make a new system come alive. And we need to take advantage of lots of statewide efforts, the state SIM grants that are happening, which, you know, are now only being used for the elderly. And what we need to be thinking about, and this is a major project I'm involved with, is the Child Health System Transformation Initiative. And it's designed to leverage the Affordable Care Act and to transform systems towards 3.0 design and rapidly establish changes. And what we aim to do through this Child Health System Transformation Initiative, we want to have thriving children's hospitals that are improving the quality of children's health care. We want to have catalytic community health centers that are developing community accountable health systems that are optimizing the health of children. We want a 3.0 school-based health centers that are prominently positioned and financially sustainable as centers of community health. And in LA, we're creating, 13 wellness centers in the LA schools, but we want to see that spread and move forward. We want to see 3.0 system prototypes. We want to see states with an enhanced capacity to actually ensure that the ACA is being implemented for kids in the way that needs to be done. And so what we're doing, we've conceived this, there's a whole group of people working on this from across the country, from Stanford and Hopkins and Penn and Harvard and Washington. There are all kinds of folks working on this. And part of what we're trying to do is recognize the potential to move forward. And we have a basic model. We want to transform the health system, so how do we line stuff up? How do we analyze national data? How do we track communities? How do we start studying and working with each of the sectors the children's hospitals, the clinics, school-based health centers. So we're thinking about moving towards 3.0. How do we mobilize and start to have collective impact? How do we take all 2,000 school-based health centers and have them start working together towards this end of putting in place wellness centers in communities? You know, how do we form new partnerships to do that? How do we have rapid learning, because we know how to do this rapid learning now through a whole variety of quality improvement methods that we've been doing for the last 15 years. How do we bring that to bear on this so we're rapidly creating prototypes that can scale and move forward? How do we start to think about ourselves more like Apple or Google rather than thinking about this, how we operate in the past? So that's what this initiative is about. And we've had several analytic papers. There'll be a paper in JAMA coming out in May, and in JAMA Peds. There are a whole bunch of papers coming out about it. There's an analytic framework. There's been 3 national stakeholder meetings in this regard. There's a national network that's been developed to move this forward. And any of you that are interested in this, happy to talk with you about it. And basically what we're trying to do right now is create a national platform for learning and innovation, and that serves as a backbone for a national network that wants to see the health system change. We're trying to create a communication and learning system so we can do analysis, modify care, and start prototyping and leveraging what systems should look like across these different sectors of the child health system, looking at policy and using the data that we have and creating new data. We've been able to bring people together from different data sets, and they're bringing it together so that we can actually start develop dashboards rather than having rear view mirror data from 3 years ago. And we're trying to prototype what this starts to look like. And one of the ideas that we have is actually working with 10 communities across the country that want to commit over the next 10 years to transforming their health system. And there's a group here from UCLA and from Penn and Cincinnati Children's and Stanford and Rochester and Urban Institute and RAND working together to try to put this project together, and we're talking with CMS about doing it. So to conclude, we need to put children first in a transformative way. We need a new powerful narrative that children are not healthy, we're not investing enough, that we have a broken system. We need new game-changing strategic approach. If we're going to move forward, it's not about fixing what's broken or incremental R01s for the next little thing. It's about what are we going to do to get to the next level. And we need that kind of thinking. We're about discovery and innovation. Let's really focus on discovery and innovation in terms of what needs to happen. We need transformative tactics, to address the challenges, the barriers and constraints. We have private love for our children. That doesn't translate into public commitment. We have all these structural organization and finance barriers, but we know how to deal with them. And we need to bring different people together to work on it. This year I'm a visiting scholar at the Federal Reserve Bank in San Francisco, and I'm meeting with bankers to talk about how do we finance things differently. Not with health insurance economists, but with people that deal with other kinds of fiscal instruments. How do we start thinking about things differently? And how do we start creating and leveraging opportunities so that we can move the Affordable Care Act? We use this new science that we have that basically says there's a lot of leverage and a lot of importance early in the lifespan, and we're missing the boat in terms of saving money and changing health. And how do we join forces together here and across the country so that we can have collective impact over the next 10 years? Or else we're going to squander an opportunity of a generation to actually change the health system, not to mention the opportunity to actually change the lives of millions of children in the United States. So if you want more information about the Life Course stuff, there's stuff on the Life Course Research Network. We have a whole series of publications that were just published in the Maternal and Child Health Journal. And if you want other information about the Child Health System Transformation Initiative, I'm happy to talk with you about that. So that's it. If there are any questions, I'm happy to take it. I know we're sort of at the end of our time.